Hello, as you know, I'm Mark Rickenbach, GP near Southampton, Southern England, and Professor of Healthcare at Winchester University. And thank you to Otto and Sahar for their presentations. I'm going to talk about the UK situation, and I'll talk about the primary healthcare background, the research, and the future, much as Otto and Sahar did. My messages from this talk are: everyone can help increase continuity of care within their practices. Discuss continuity with patient groups and all the care team to help look at ways to move it forward. Teach about continuity and relationship-based medicine, particularly if you're a postgraduate educator. Use the Continuity of Care Toolkit on the RCGP website, and I'll give you the links shortly, and consider a continuity of care lead in your practice or working environment, or getting an external facilitator. Primary healthcare in the UK is in crisis at the moment. There is some move towards transactional care based on individual items of care rather than the whole picture. There's increasing workload, and that has affected morale, particularly after the COVID pandemic. There's low GP recruitment in the UK with a high rate of retirement. So it's all coming together at once. General practice partnerships are led by GP partners, and I think they are highly cost effective because they merge several roles, and to replace them needs several people. GP partners are involved in administration of their booked patients, of patients on their personal lists, and all the leadership that's involved. So there has been some merging of primary care partnerships. Small partnerships provide better continuity because there's one or two doctors, but the workload is high. So sharing the management does help. There's also been a move towards salaried organisations where GPs have left practices and there's no GPs to run them. And these are mainly in the inner city areas and involve multiple surgeries. I have concerns about continuity in this setting, but that's the message today, is to increase it. We also have primary care networks emerging in England, and these have led to the combining or working together of several practices between 30 and 50,000 patient size areas. And they've also brought in additional roles, including things like first-line physiotherapy, a social prescriber, pharmacy, paramedics, and mental health nurses, which have to some extent diluted continuity, but again, we need to tackle that. And as Otto implied earlier on today, there's a paradox of continuity. As the workload increases, continuity is actually falling, at least in England it is. So there's higher costs, more urgent care, and greater workload. As workload increases, we actually need to increase continuity more, because that would reduce costs, reduce urgent care, and reduce workload from the evidence we have. The COVID pandemic has shown how important continuity is. We're talking about relational continuity between a doctor and patient. Bear in mind there's informational continuity working in the background, and continuity in the medical records, and organizational continuity, the continuity of an organization over time, which maintains its relationship with the community. I think that continuity face-to-face before the pandemic has helped us to provide phone call care during the pandemic. And I don't know about you, but I found myself visualizing my patients in front of me, and then surprised, since I've seen them after the pandemic, whether they've changed in shape, appearance, or age. Less face-to-face contact, which is occurring in our health service, is reducing those cues, physical cues, reducing rapport, and it takes longer to develop relationship and continuity when there's less face-to-face contact, as is the trend generally. This slide looks busy, and that's intended because what we're showing here is the evidence base for continuity of care. And I want to stress that it's extensive. There are not randomized control studies, apart from the area of continuity in midwifery, which shows benefits. But there is a collection of evidence over many years which is consistently showing continuity helps. There is no strong evidence saying there are disadvantages, and I'll touch on those later that might be there. If you see the usual GP 2 or more times out of every 10 consultations, there's a 6% associated decrease in urgent care, as shown by Barker in 2017. And that paper led to further work that's taken place in England with the Healthcare Foundation. So we note that patients are more satisfied, that they follow more medical advice, they take up more preventative medicine, they have a better doctor-patient relationship, they receive better quality care. There's reduced A&E, hospital admissions and urgent care requirements. That's for patients. For doctors, there's greater accumulated knowledge with continuity of care, more professional satisfaction, better problem recognition, quality of management, less conflict of responsibility, since you know which doctor is looking after who, less costs, prescription and tests, less cases of avoidable harm, and crucially, reduced mortality. If you want more information, read the work by Pereira Gray. And we've got this brick wall of evidence that we have in front of us. So the research project in the UK and England looked at continuity of care from the point of view of how we can implement continuity of care rather than what's the evidence. And between 2019 and 2021, the Health Foundation Continuity of Care programme, which was supported by the Royal College of GPs, covered 5 sites and 500,000 patients. There was Morecambe Bay in the South Cumbria area, Valentine Health in London, 1 large practice, One Care and Peer Health in Somerset near Bristol, which set up further advice for people to apply continuity. And St Leonard's Group in Exeter, which is very involved with collation of evidence and writing reports on evidence base. And the aim of this programme was to determine if continuity of care is achievable and can be increased in the UK. Peer Health in Somerset showed an increase in continuity despite increasing workload and demands in a deprived area. They reported that joy in work, enjoying your work, makes that workload easier. That access and continuity can both be improved rather than one or the other. And their statement is you need access to continuity of care. I talked about potential risks and disadvantages of continuity. And one is that if you see the patient more often and take responsibility, you might find that responsibility quite a weight. And some doctors reported a heart sink feeling in themselves, not a heart sink patient, which is important to stress. It's a feeling the doctor has if they're under pressure. We provided advice on how to handle that heart sink feeling in the doctor and showed that if you relate to that patient more often and think about their social history and past, you can overcome it and indeed convert it to a positive feeling. St Leonard's practice in Exeter has a website, Continuity Counts, which gives advice on improving continuity. And some of the work they've done since then on dementia has shown reduced admissions, reduced delirium by 35%, reduced incontinence by 57% with continuity of care. And the reference is there. One Care and Morecambe Bay have produced a continuity of care toolkit, which is really good and is on the RCGP, our Royal College of GP's website. The link is there. And also an overview of the programme is there. Do go and look at that. It don't make such a difference. Valentine Health in London has showed a reduced A&E and urgent care centre usage and less antibiotics in keeping with the existing literature. They increased continuity from 30 to 65 to 75%. That is 30 out of every 100 consultations with the same doctor. And they introduced microteams. Continuity on surveys was wanted by 78% of patients in that practice. and 88% of staff supported the concept of continuity, particularly for subgroups. And when continuity increased, there was increased satisfaction for patients, staff, and GPs. So the message coming out from the programme is tailor the interventions to improve continuity to your practice. Tell everybody in the practice the benefits of continuity of care and remind them about the evidence. Use case-based stories. We haven't used them much today, but they do actually take people along and make them understand the realities of how continuity can help and make an earlier diagnosis. I remember a patient who came in with a hemoglobin of 3 when they were tested, but everybody thought that they were just their usual self. When I saw them, they just looked a bit different, and something made us do a further test. Involve all, including patients groups, reception, all staff and the doctors in improving continuity. It's a team effort. And measure it. Look at dashboards that will give you that information, and there's one emerging now. You can join the continuity of care community at the Royal College of GPs to get further updates. You would have heard, I hope, this morning about relationship-based care. Relationship-based care, building that relationship between the doctor and the patient to improve care. The point about it is that relationship-based care is what you're aiming for, and continuity is almost a proxy measure, but it is what you need to establish relationship-based care. You can have very good relationship-based care in one consultation, but you need to think about follow-up anyway. But having regular continuity really helps that relationship. And as Martin Marshall says, if a trusting relationship between a patient and a health professional were a drug, we would marvel at its effectiveness, and NICE would mandate its use in every consultation. What is the future in the UK? Well, the British Medical Association local medical committees at their last meeting produced a resolution to prioritise continuity over access. That's really good. It's a step forward. But I would say continuity can improve access, and they both go hand in hand. The Health Select Committee of the UK government has been looking at continuity of care as well as other ways to improve healthcare provision. And you could look at Sir Dennis Pereira Gray's article in the British Journal of General Practice for more information about all those practices that are continuing to provide continuity of care. And those practices and those in the health programme have shown an increase in continuity of care against a national background of a fall. Systems now exist to report continuity and appointment usage right across the UK and in other countries. There is an APEX module which can go with EMIS and System 1, which are the systems used in the UK, which will report continuity and demand and access management. That's a big step forward within the last few months. We think there is a need for an economic evaluation of the benefits of continuity of care. Our estimates are that they are considerable, but a proper economic evaluation would help, and I think would guide government policy. There will be a need for continuity across and within teams, with all these additional roles coming in to support and replace the GP sometimes. And integrated care boards have been introduced in England, which should focus on continuity and help to bring them together. So I'm going to end at that point and we'll open up for discussion, but a reminder and a question. What step will you take to increase continuity of care within your practice, your working environment? A reminder to discuss with continuity of care with patients and all the healthcare team and remind them on a regular basis. Teach about the wall of evidence for continuity of care and relationship-based medicine within your practice, but also as a postgraduate educator, teach medical students and those in vocational training. Use the continuity of care kit, which is available on the RCGP website. Pick out bits that are relevant to you at whatever stage you are. A little bit here and there will nudge it forward. And have a look at the overview on the RCGP webpage. And consider a continuity of care lead within your working environment, or get an external facilitator. Thank you very much indeed. I'm going to move on to the question session now.